is it unusual for someone to be diagnosed with Mets to their bones at this late stage in their early 80s? Like how common does that happen?
It's not a common occurrence to be diagnosed with metastatic disease and high-grade cancer. However, there are exceptions. Some people don't make PSA simply, and so the screening test, even if you're screened, doesn't work. This is like 2% of all patients. Most people will be picked up with PSA early, diagnosed, and then often cured.
Okay. And, I think a lot of people are wondering, I know that the U.S. Preventive Services Task Force recommendation for men over 70 is against routine screening. The American Cancer Society says to have a conversation with your doctor about it. Um, can you explain why it is that in general, men over 70 are not recommended to have routine PSAs?
It's because they put a life expectancy on the test, as opposed to really looking at the individual. Some people can be 50 and live 5 years, and some people 70 and live 25 years. Primary care physicians, though, know their patients well and really are in the best position to assess whether someone at 70 or 75 or even 80 should be getting a PSA or not. It's clear, though, that when you get a PSA, you pick up cancers earlier and you're much more likely to cure them. The data has borne that out. The reason why 50 to 70 was adopted is all the screening studies looked at people in that age group. It doesn't mean that there isn't benefit beyond that age, especially for people in otherwise good health.
Okay. And it's hormone positive, meaning that he should probably initially be treated with hormone therapies that block testosterone. How effective are those treatments typically for patients? Yeah.
So essentially, almost everyone who presents with a Gleason 9 with metastatic disease will be hormone sensitive. That is, the hormonal therapy will work, they will respond, and that response can last typically on average 5 to 6 years, sometimes longer. The way you figure it out is once you start them on the hormonal therapy, if their PSA goes to 0, becomes unmeasurable, those patients live the longest. They can live easily a decade, given the number of treatments we have within this particular disease space.
So it's possible that he could start off with hormone therapy. It could be very effective. Maybe it stops working after some period of time, but there are other treatments that can be attempted at that point.
Absolutely. There are many lines of treatment for prostate cancer in more advanced stages. One other point I should make is that there is now a new set of patients with metastatic prostate cancer, high scores like Gleason 9 or 10, in whom, if they only have a few metastatic sites, that is typically less than 3, that we treat them aggressively, not only with hormonal therapy, but actually they use radiation therapy to sterilize the metastatic sites, because there's accumulating information that not only delays time to progression, time to the hormonal therapy stop working, but there's a possibility you might even cure some of these people.
So you can still talk about potential cure even in someone with this late stage.
You can talk about it. We haven't proven it yet, but it's out there. We have people out 5, 6 years with an exact presentation, Gleason 9, only a couple of metastatic sites, who 5 years later still have an undetectable PSA, just on hormonal therapy, and had radiation to those sites 5 years ago.
Is it likely that he would have developed prostate cancer and it would have advanced this quickly in the past 4 to 5 months, say? Or is this likely something that's been around for a long time that just wasn't detected up until now?
So there are different types of prostate cancers. They get scores, 6, 7, 8, 9, 10. 8, 9s, and 10s, particularly 9s and 10s, can grow quickly. Growing quickly means that they could have been there for probably not more than a year. And so, I think that one has to really recognize that when you're dealing with more aggressive prostate cancer, a year ago, the PSA could have been normal, and a year later, it could be 25.
So even if he had been screened with a PSA test in 2024 during his last physical, which it sounds like he wasn't, it is possible that it could have been normal or near normal, and it would not have predicted that he'd end up in this state now.
Right, but if you have serial PSAs, so if you have one every single year, this is where the number matters less, the trend matters more. So for example, normal is 4. So if 3 years ago the PSA was 1, a year later it's 1.5, a year after that it's 3.8. Even though it's still normal, that should catch people's attention. So you can look at more than just PSA level. You can look at the trend over time, and that can spark the need for an MRI and a biopsy.
And so what would your recommendation be to the average man out there about prostate cancer screening, just in general?
So for people who do not have a family history, are not from high-risk backgrounds, Hispanic, Latino, African American, starting at 50 is very reasonable. And every year thereafter with a PSA test. It's been proven by the Europeans to reduce death from prostate cancer by more than 25%. For men who have a family history, dad or a brother with prostate cancer, or are in those high-risk populations, African American, Hispanic, Latino, they really should be starting earlier because cancers in those men present at younger ages, as early as 40. So they should be starting at 40 and then every year thereafter.
And digital rectal exam, less important, not as
The
common?
digital rectal exam is only important in that group I mentioned earlier, which is men who cannot make PSA. That's rare, that's 2%. They typically present with symptoms, urinary symptoms that are not, just frequent urination, but almost like can't urinate at all, or blood in the urine, or blood in the ejaculate. But this is a rare group, this is 2%, and PSA will not find those patients.
And then oh, go ahead, please.
DRE would be the only one.
And when you saw last night or woke up to the news this morning that former President Biden had Gleason 9 score prostate cancer, were you surprised that someone who had been a sitting president just 4 or 5 months ago would be diagnosed with a cancer at this late stage, or was this not at all surprising to you?
So the people who get the most advanced cancers are the elderly. We know that advancing age is one of the highest risks for getting an aggressive prostate cancer. And so if you're in good health, 82 or 85 or 75, you should be getting a PSA. And I understand there's some hesitancy by the primary care physicians to think about this, but we are so much better now than we were in terms of who needs treatment and who can be watched or surveyed. And so I think people should feel less concerned about being over-treated, which is why there's a hesitancy about getting PSA. If they're in good health, 80, whatever, that's where the high-grade cancers come into play. Those people, in my opinion, should still be screened.
All right. Is there something I should have asked you that I didn't?
The other thing is just something that people should have in their own backyard, and that is they know their family history. Most people know their dad and their mom and their siblings. Prostate cancer can be linked to breast cancer and colorectal cancer and ovarian cancer. So if you have a sister or a mom who had breast or ovarian cancer, you may be more likely to get prostate cancer genetically. Colorectal is similarly with a brother or a parent. So I think people should know their family cancer history, because then they can go to the primary care and say, my dad, had colorectal cancer when he was 45. My mom had breast cancer when she was 52. I'm concerned. I know that what's not prostate, but I'm told that they're linked. Maybe I should have a PSA.
All right, doctor, thank you so much for your time. I really appreciate it.
It's very nice to meet you.
You too.